Our symposium plans looked, at least in my mind's eye, was somewhat like a Tony Robbins live event. We were looking for the hundreds of thousands, maybe need to rent out the Husker Stadium. But true to what I see a lot of on social media, I felt like I had to give our plans versus the Delta variant meme here. But my objective is really, I wanted to put the principles up front, not just to learn, but to see again.
Dr. Bennion, we cannot see your screen.
Oh.
Yeah.
Let me share again. All right, are we able to see that now?
We're good now.
Great. So here was my symposium plans, Tony Robbins live, and then my meme, the Delta variant. Yes, that's a box of goldfish. So objectives and principles to show again how and where radiation works in advanced and high-risk endometrial cancer locally, the local regional benefit. Chemotherapy, we see over and over how it improves distant control, and then how the two of them can work together to improve overall survival. We're going to look at it and confirm, yes, we do have a number of trials that are heterogeneous, and it's tough to say that they build on one another as a very sequential nature, but that these trials can still inform our decisions. How do we do that? And future directions. So last year I had some feedback that with our nurses, therapists, dosimetrists, and physicists, that I could do a better job of getting them some information. So again, kind of some review, the stage of endometrial cancer. Stage 1, limited to the endometrium and less than 50% invasion. Stage 1B, more than 50%. Stage 2 into the cervix, which these will be relevant in what we're discussing. And then stage 3 and 4A are beyond the uterus. So surgery is undoubtedly the backbone of treatment, of curative therapy. And the questions that remain at hand are who needs adjuvant therapy and what kind, or even what sequence. So kind of to describe a little further, these are different ways that people break it up into risk groups for early stage. So this has been looked at a lot, and our risk factors that will be persistent through this talk are grade, depth of invasion, lymphovascular space invasion, age, and I'd say to a second sort of stage is size, lower uterine segment involvement, cytology. And then you can see that ASTRO has a somewhat set of guidelines that help us to make these decisions in the clinic, to take the trial information. Now transferring over to high risk, these are patients that have 1B, so that's greater than 50% invasion, and grade 3, stage 2, 3, or 4A, and then any patients that have what we call high risk histology, so serous, carcinosarcoma, and clear cell. And some would include undifferentiated. So you can see it down at the bottom that this is a wide group of patients, and this is where the difficulty comes in these trials, that having a 1B and grade 3 is a very different patient than someone who has cancer that is moved and confirmed into lymph nodes and may also have a high-risk histology. So the guidelines really show us the problem. For 1B grade 3, you can see radiation, external beam with or without brachytherapy, with or without systemic therapy. So we've got 3 separate entities that it could be treated with. Stage 2, you'll find the same. Stage 3, you'll find the same. And it's all plus or minus, and then high-risk histologies, a similar pattern. And so it's sort of a murky situation of what do we really do. With the background, is in terms of retrospective studies, we see that radiation improves local regional control and that chemotherapy was improving the rate of distant metastases. Also show that disease-free survival improved with external beam radiation. In fact, in their series, there were no local regional failures, and concluded that perhaps then adding chemotherapy would improve the overall survival if we've got such good local and regional control. And then the GOG showed some patterns where if they had whole abdominal radiation, it was mostly out of field failures. Then we look at chemotherapy alone historically. So Munt et al. Showed that CT chemotherapy still had up to 88% pelvic recurrences in advanced endometrial cancer, thus showing us that despite the benefit that they do show, that there's still an increased risk of local and regional failure. And Selman et al. Demonstrated similar findings. When we combine it, we see again, when we combine therapy, Graven et al. Lowered local regional failure and distant metastasis. We see this through the rest of these studies, but again, note that none of these were category 1. So then come prospective randomized studies. One of the larger was in a pooled analysis of 2 European trials where they added sequential chemo and radiation, and it was in either sequence. And these were for patients similar to some that we'll look at today. And what we see here is an improvement in progression-free survival and a trend towards overall survival. So then we have contemporary studies that were created for this. And GOG 249, this is an earlier, and I'd say of the 3 that we'll discuss heavily, this was the most homogeneous group because they chose patients that had mostly confined to the uterus and cervix. So serous or clear cell were included, and then endometrioid, any stage 2s. And then if you were stage 1, you needed to either have a certain age and a specified number of risk factors that we discussed. Again, so the external beam versus vaginal cuff brachytherapy and 3 cycles of carbotaxol. I'll point out that the 3 cycles is different in that historically it was 4 to 6. And we saw no difference in relapse-free or overall survival. But what we do see, I'll call attention to again, in the pelvic radiation, we had lower pelvic failures, but higher distant failures because there was no chemotherapy. And in the chemotherapy arm, decreased distant metastasis, but an increase in pelvic failures. When we look at toxicities, this is a trend that we will see persist through these trials. That largely the radiation alone, grade 3 or higher toxicity is around 10%. And this is consistent with our time C trials looking at 3D or IMRT. Grade 3 was, I believe, 10 and 12% in external beam. And then 64% in the vaginal cuff brachytherapy with chemo arm. Most of these primarily in the hematologic and neurologic sensory. So next is PORTEC-3. This is a group of more of a higher risk, and it's external beam to the pelvis compared to adding chemotherapy, both concurrently and adjuvantly. So again, higher risk histologies, and then the more advanced endometrioid stages. They did include 1As if they had grade 3 and LVSI. Once again, very heterogeneous population. And what we see here is an improvement in relapse-free, failure-free survival, but no improvement in overall survival at the specified endpoint. Until a year later, an update, which was a post hoc analysis, demonstrated overall survival in both, in all patients. We did see a stronger benefit in serous and grade 3, so something to consider. In terms of patterns of failure, this showed similar patterns where if you had, what we still saw was that distant metastasis was predominated. As far as toxicity goes, we do see that adding chemotherapy to radiation increases grade 3 toxicities. And you can see here from radiotherapy alone, 12%, what we expected, up to 60% if we added chemotherapy to the regimen. Now note that those are similar numbers to that of 3 cycles of chemotherapy. In the last study, GOG 258, chemoradiation plus that, so this is the PORTEC-3 chemoradiation arm with 4 cycles of chemo versus just chemotherapy being 6 cycles. This was a more similar population, I'd say even a little more advanced compared to the PORTEC-3. But again, we see here a non-statistical difference, and even a tough to determine any numerical difference in recurrence-free survival between chemotherapy only and chemoradiotherapy. Now, when we look at patterns of failure, we see again the same pattern. Vaginal recurrence higher if chemo only, pelvic recurrence higher if chemo only, and distant recurrence improved with chemoradiation, or worse with chemoradiation. Toxicities again, all similar to that of PORTEC-3, but note in the chemotherapy arms, we still have a very close, it's not as different when we have chemotherapy in both arms. So take home points at a first glance. High risk from GOG 249, high risk uterine cancer confined with confined disease. Chemotherapy and vaginal brachy is more toxic than external beam. So that begs the question, why do we continue to see vaginal brachy with chemotherapy? And then in high risk and advanced endometrial cancer, that if we add chemotherapy to radiation, it improves possibly overall survival, but at least relapse-free survival. Then in high risk and advanced endometrial cancer, chemoradiation does not demonstrate an improved relapse-free survival over chemo alone. So the difficult part here is you could have a stage 2 and you could still offer them any one of these: whole pelvic radiation, concurrent chemo radiation and adjuvant radiation, or chemotherapy alone. So how do we look at these in context with one another? Well, we can see that external beam decreases vaginal, pelvic, and PA recurrences with or without chemo. And here's a pop quiz. What was it in 258 that increased distant metastases? Was it adding radiation? Was it a delay in chemotherapy, waiting for radiation? Or was it decreasing the chemotherapy dose? I'll let you be the judge. So what I perceive from this is that chemotherapy decreases distant metastasis and the dose, not going down to the 4 cycles, and timing matters. PORTEC-3 and GOG 258 tell us that adding chemotherapy to radiation improves overall survival from PORTEC-3, and that adding radiation to chemo improves local regional failure. So for me, this changes my practice some, in that I consider chemotherapy as more important in terms of timing. The next item I'd like to draw your attention to, GOG with external beam radiation, grade 3 toxicity, and the PORTEC arm again demonstrate 11 and 12% grade 3 toxicity. But whether you're giving 3 cycles, 4 cycles, or 6 cycles of chemotherapy, our grade 3 toxicity looks to be the same. And this is with or without the radiation arm. So in terms of patient toleration, so pop quiz, what's the rate of grade 3 toxicity for vaginal cuff brachytherapy? How much did it add? The answer to that is virtually none. If we look at PORTEC-2 and any other retrospective, I would say it gets up to about 3% in some studies. So we see here that 3 cycles of chemotherapy has similar grade 3 toxicity rates as 6 cycles. Now, per the GOG 249, if it was just the chemotherapy 3 cycles followed by brachytherapy, there are NCDB studies that looked at larger populations to see in the real world what were the outcomes. Now, these are hypothesis generating studies because it's a population study, not category 1 evidence. But they show similar outcomes that with vaginal cuff brachy and chemotherapy, arguably the losing arm of GOG 249, that there is an improvement in overall survival in stage 1B patients, as well as outcomes in serous and grade 3 if they were unstaged in the pelvis. And so what we can see here is that retrospective studies with our current evidence may still suggest a survival benefit of chemo with better selected patients, particularly those with serous carcinoma. In terms of decision-making, taking all of these trials into consideration, we need to consider tumor factors or patterns of failure, patient factors like performance status, which that's where the toxicity similarity between number of cycles of chemotherapy and the perceived difference in distant metastasis and survival seen when decreasing from 6 cycles to 4 cycles, as in the GOG 258, and then also treatment factors of toxicity. So for my thoughts, and these are not multi-D guidelines, but when I look at this, my thoughts inspired by 249 are this: that if they're a candidate for 249 with lower risk of distant metastasis or a very poor performance status, then external beam radiation alone will have an equivalent relapse-free survival with a much lower risk of grade 3 toxicity. Next, just a thought that we see a pattern only in retrospective studies that clear cell carcinoma is not as responsive to chemotherapy as, say, its counterpart, serous carcinoma. And so an early clear cell carcinoma with lower risk factors of distant relapse, that they would also be candidates for external beam radiation. And then early serous patients, as discussed and demonstrated in the population studies, the chemotherapy followed by vaginal brachy or external beam radiation could be considered, and we might consider more than 3 cycles, depending on risk and the patient's performance status. My thoughts inspired by the GOG 258 and interactions with PORTEC3 would be that stage 3 or serous with high risk of distant metastasis may warrant for 6 cycles of chemotherapy and then a consideration of external beam radiation with or without vaginal cuff brachytherapy to address that pelvic and regional failure. And then the GOG 258 candidate with borderline performance status that may tolerate chemotherapy, that the thought could be to start with the 6 cycles and reevaluate for radiation. Inspired by PORTEC3, patients that I would consider most for concurrent chemoradiation with adjuvant radiation therapy would be those with gross residual disease and highest risk of local regional recurrence. And in that case, the chemoradiation with the chemotherapy, but the question still, should we increase those cycle numbers of chemo from 4 to 6? As far as where we'll go from here, in 2013, we saw this study. And it was, that's my alarm. So I'll wrap up here, but we see that molecular studies are playing a larger role. In short, when we divide endometrial cancer patients in the low risk, PORTEC2, who randomized from external beam to vaginal cuff brachytherapy, is able to separate very well both the cancer-related survival and pelvic recurrence by these mutations. PORTEC3 then more recently came out with a similar molecular analysis. So this is the advanced endometrial counterpart, and they show a similar separation. The P53 abnormal having the highest risk of relapse. Then, and on the other end, the POL-E mutated patients having the best or almost no relapse despite the ARM. And then R2, the mismatch repair deficient and no specific molecular profile hanging somewhere in the middle. We see here how it could direct us is that the P53 abnormal endometrial cancers have an improvement with the chemo added to radiation. We also see that there's a benefit for the mismatch repairs, no difference between the chemo and chemoradiation. Some other points that 2/3 of patients will have at least one actionable alteration for an FDA-approved agent or experimental with a current trial opening. Mismatch repair and polymutated, they respond well to immune checkpoint inhibitors. That also we see the mismatch repair deficient, they respond well to PD-1 blockade. And then of course HER2 for serous carcinoma, which has had more recent evidence as of late. So Europe has included these now, as you can see, into their treatment recommended guidelines. I'd say that as time moves forward, it looks like these really will fruit for us. Thank you, and we'll move to the next speaker. Now we'll be privileged to hear from